Welcome to In a Heartbeat. I'm Dr. David Balle, and I'm your host for In a Heartbeat, filmed here at the Grosse Pointe War Memorial, WMTV, in Grosse Pointe Farms. Today, I'm very excited to have as my guest, Dr. Paul Cullis. Dr. Cullis, I'd like to welcome you to In a Heartbeat.
It's a pleasure to be here.
And thank you for taking time out of your busy schedule to be with us today. And Dr. Cullis, so our audience has some background on your specialty and your role in the community. Maybe you can just tell us about the focus of your work and what you do at St. John Hospital and Medical Center.
I'd be happy to do that. I'm a neurologist. Neurology is the specialty of medicine that deals with the treatment of diseases of the nervous system, the brain, spinal cord, peripheral muscles. Neurologists commonly see a lot of conditions, but the most common one is stroke. My training was at Wayne State in Detroit, and then I joined the staff at St. John Hospital, and I've been chief of neurology or head of neurology at St. John Hospital on Maras since about 1998. I'm also the medical director of the stroke program at St. John. In addition to being certified in neurology, I'm also certified in vascular neurology, which basically just means stroke. There's now a subspecialty certification by the board in vascular neurology, which has been available for about 10 years. We're very excited about the stroke program at St. John because we've recently gone to the highest level with that program. We've been certified as a primary stroke center at St. John for about 10 years, giving clot-busting drugs and other appropriate treatments for stroke. But as you may be aware, nowadays it's possible for doctors to actually go in and pull clots out of the brain and restore blood flow. Cardiologists have been doing this for some time. Everyone knows about heart doctors doing stenting and angioplasty on the heart, cardiac catheterization, and they're a little bit ahead of us, but now we have doctors on staff, both neurosurgeons and neurologists, who can put a wire into your groin, thread the wire up into your brain, and unblock an artery in your brain and restore the blood flow, which is really pretty close to a miracle.
That's amazing. And that's such an asset to have in our community for residents who live in the area.
Right. So if you can prove to, the organization that certifies hospitals is called the Joint Commission. And if you can prove to the Joint Commission that you can do those things appropriately, then you get certified as a comprehensive stroke center, which is the highest level. And that happened to us actually about 2 days ago. We were surveyed by the Joint Commission about 6 weeks ago, and we got the final letter of approval yesterday. So we're very excited in that we can provide the same kind of advanced care in stroke that one could receive at any major center in the country.
That's an amazing accomplishment. Congratulations. I'm sure it took a lot of hard, coordinated effort and work in order to achieve that.
A team of about 30 people working for about 9 months, yes.
That's great. So Dr. Cullis, for those in our viewing audience who may not have the knowledge that we have about your specialty, what is a stroke and are there different types of strokes?
Yeah, that's a very important question. Stroke is what we sometimes refer to as a brain attack in the same way that we talk about heart attacks. If you have a heart attack, you lose blood supply to part of your heart, you get crushing chest pain, you feel like you're going to die, and you have to get rushed to the hospital to get very rapid treatment. When that happens to your brain, it's called a stroke. A stroke is a problem with the blood supply to the brain. It's an emergency. The reason that patients in the past didn't get to the hospital quickly enough is that you don't get pain when you have a stroke. It's usually the pain, or it was in the past, the pain that brought people to the hospital. So now we're trying to emphasize to the community the importance of when you have a stroke, you must go to the emergency room immediately, because the longer you wait, the less likely it is that we're going to actually be able to make you better.
And before we continue further, just so people are aware, what is the time frame that people really have to work with if a stroke is developing between recognizing that and having it taken care of?
Right, well, what we're talking about here now is ischemic strokes. There are two different kinds of strokes. One of them is ischemic, where there's a lack of blood supply to the brain. That's probably about 85% of strokes. And about 15% of strokes are hemorrhagic. In other words, a blood vessel broke and you bled into your brain. That's kind of a different issue. If it's an ischemic stroke due to a blockage of an artery, then we really would like you to come to the emergency room within 2 hours of onset. In other words, if you wake up with a stroke or if you have a stroke, you should immediately come to the hospital. The best outcome is going to be if you get to us within 2 hours. Mm-hmm. We can still give you clot-busting drugs up to about 3.5 hours. The actual guidelines are 3 hours and 4.5 hours, but it takes us about an hour to get there. Mm-hmm. So if you want to get in within the 3-hour window, you really need to come in 2 hours so that we have an hour to actually do what we do. So the ideal is come in 2 hours. If you come in within 3.5 hours, we can still give you a clot-busting drug. If you come in after that, we might still be able to pull the clot out of your brain, but time is brain is the expression that we use, and every minute that you delay, thousands of brain cells are dying, and so time is really of the essence.
And so, as a follow-up to that, what are some of the signs and symptoms that people should be aware of so that if something like this is happening, they can try to take immediate action?
Right. So the expression that we use is FAST, and that stands for face, arm, speech, and time. So if you have one side of your face drooping, if one of your arms is feeling weak, if you're slurring your speech or having trouble talking, it's very important to go to the emergency room in a timely fashion. So that's FAST. And then some people would expand that to include trouble with vision and difficulty with coordination. In other words, if you're having trouble walking, if you're having double vision or trouble seeing, those are also important issues too. And I think really the important thing is to err on the side of caution. If you think there's any chance that you're having a stroke, you should go to the emergency room, because the good news might be that you're not, but if you are, you really need to get urgent treatment if you want to get back to normal.
And you probably see this, unfortunately, a lot of times. A lot of people will tend to maybe kind of discount something or rationalize in some way. And what would you say to somebody who says, gosh, I don't want to embarrass myself, or I think it's this or that?
Yeah, I think the emergency room doctors are very used to seeing patients who don't really have a lot of medical problems. It's way better to be overly cautious. I mean, the worst thing that can happen is the doctor can say, well, I think this is actually maybe a pinched nerve in your neck. I don't think it's a stroke. I don't think it's an emergency. That's good news. But you really can't take a chance. If there's even any possibility that you're having a stroke, you should go to the emergency room or immediately get medical attention, because if you come in the next day, I'm not going to be able to do anything for you.
That's sage advice. So, Dr. Cullis, what are some of the risk factors involved with stroke, and what, if anything, can be done to prevent it, and how can we make ourselves healthier with that?
One of the risk factors that we hear about a lot on television nowadays is atrial fibrillation, or AFib. It seems like every time I turn on commercial television, I see an ad for a drug that's going to stop me from having a stroke if I'm in AFib. So that's a very important risk factor. If your heart flutters, if you have an irregular heartbeat, you may well produce blood clots in your heart, which can then go to your brain and cause a stroke. And anybody who has symptoms, who has atrial fibrillation, should be on a blood thinner. In the old days, we used to put people on Coumadin, which is also called warfarin, but there are a whole host now of new anticoagulants that work better and are safer, including Xarelto, Eliquis, Pradaxa, and others. And so that's a very big risk factor, but it doesn't apply to most people. The risk factors that apply to most people, and the most important ones, are smoking, being overweight, having high cholesterol, having high blood pressure, a sedentary lifestyle, not exercising, and unfortunately some people also use illegal drugs. Things like smoking crack or snorting cocaine can cause strokes. So if your blood pressure is high, you need to get it under control to reduce the risk. And you know, high blood pressure is a relative thing. When I went to medical school a long time ago, we used to talk about high blood pressure being 140/90. Then it got down to 130/80, you know, and the goal for the American Heart Association now is 120/70. And unless it produces symptoms, you really, you know, it's really hard to have a blood pressure that's too low. We're really aiming for much lower pressures nowadays. So you want to keep your blood pressure certainly less than 130/80. If you're diabetic, you need to control your blood sugars. That's a big risk factor. Take your medicine, take your insulin, really try to keep your blood sugars under control. If you have a high cholesterol, you should try to lower it. We used to aim for a bad cholesterol level of 100. We now believe that a bad cholesterol level under 70 is more appropriate.
And for those people who may not necessarily know why cholesterol affects a risk for stroke, how does that play a role?
Cholesterol accumulates in the inside of the arteries going up to the brain, and it produces what we call atheroma. That's kind of a complicated word that means that you have stuff on the inside of your arteries that looks like dried oatmeal. So, and when that substance accumulates in the neck, it can block off the flow to the brain. Blood clots can form, causing clots to break off and go up into your brain, and you might actually need to have surgery or stenting to open the artery.
Many of the same things that you're recommending and advising us also go along with a heart-healthy lifestyle and diet, don't they?
They're very much the same. I mean, most people nowadays that have either a stroke or a heart attack wind up on aspirin or something similar. They wind up on a drug to lower cholesterol, and they wind up on a drug for high blood pressure, often what we call an ACE inhibitor. And the most common one of those is a drug called lisinopril, which is a generic drug which is relatively cheap, which is quite effective in lowering blood pressure and preventing strokes and heart attacks. You know, it's basically the same process. And if you've narrowed the arteries in your heart, you've probably also narrowed the arteries in your brain. It doesn't occur in isolation. And so people that have had a heart attack are at a much higher risk of stroke and vice versa.
And this is, you know, just a question I had. At what age should somebody even start to think about these types of things? Or should we always have that in mind?
Well, I think everyone should be getting regular checkups from their primary care doctor. They should have a primary care doctor who's the captain of the ship. A lot of people in our country, unfortunately, wander around from specialist to specialist, and no one's actually the captain of the ship. But I think it's very important on a regular basis to get your blood pressure checked, to get your blood sugar checked, to get your cholesterol checked, and really starting probably at the age of 40 or 50. It depends a little bit on family history. Certainly if there's a family history of strokes or heart attacks, I think starting at 40 would be very appropriate. Maybe in people that don't have those risk factors, starting at 50 might be more appropriate. But I think nowadays we really believe that most people who don't have a contraindication to it should be taking a baby aspirin every day after the age of about 40 or 50, because we know that taking an 81 milligram aspirin a day will reduce your risk of stroke, heart attack, and nowadays we know that it will even reduce the risk of colon cancer. Now, if you have a bleeding problem and your doctor doesn't want you to take aspirin, then don't take it. And always consult your doctor before starting any medical treatment. But most people over the age of 50 should be taking a baby aspirin a day.
Dr. Cullis, say for example somebody questions whether they're having symptoms of a stroke. They come to the hospital. How is a stroke diagnosed?
It's really a clinical diagnosis. It depends on the onset of symptoms that are consistent with a stroke. So what happens at our hospital is that you come into the emergency room and you're seen by the resident and the attending from the emergency medicine department. They think that you're having a stroke. They immediately contact the rest of the team. They call the neurologist on call who consults over the phone. The first thing we do is to get an urgent CAT scan of your brain. Usually that doesn't show anything because strokes on regular CAT scans don't show up usually for 12 to 24 hours, but that will allow us to know that you're not bleeding into your brain. If you're in that 15% of people who had a bleed into their brain, then the treatment is quite different. So the first thing we do is get that initial CAT scan, make sure there's no bleeding, and then start the appropriate treatment for stroke. If it's a relatively mild stroke, we may do nothing. If it's a moderate stroke, we likely will give you a clot-busting drug called TPA if you're within the time window.
And how is that administered, and how fast does that work?
It's given through an IV, so we try to start that as soon as possible. We mix up the appropriate dose. We give you 10% of it just by pushing the syringe and injecting it directly into a vein. And then the other 90% of the dose is given in an infusion over about an hour. And we do this not only at St. John Hospital, but also at a number of other smaller hospitals that we serve, because we have a telestroke network. In other words, we have doctors who are going in by television to see patients in emergency rooms at small hospitals throughout the region.
That's wonderful.
And what happens in those cases is that you get the TPA started in the emergency room, for example, at Mackenzie Hospital in Sandusky, and then they put you in an ambulance and send you down to us so that we can continue the treatment. So that has become the mainstay of treatment of stroke throughout the region. And then if that doesn't work, or you can't get TPA, then we will see if our doctors who do these procedures can go in and actually remove the clot from your brain, and we try to do that very quickly as well.
And how effective are the treatment outcomes?
The treatment is very effective. TPA often improves the situation. If it doesn't, then often doctors are able to go in and remove the clots and restore blood flow. So a lot of times it doesn't work, unfortunately, but it's the best treatment that we have, and it's important to get it to give yourself the best chance of recovery. You know, one of the most frustrating things that a person can experience is not being able to talk. We're sitting here today having a long conversation, and we take it for granted. If patients have strokes, often they're not able to talk. And that is probably the most frustrating thing that can happen to a human being. So if you start to have trouble talking, you have to get in immediately, because for any of us and for most people in the world, not being able to talk is going to be a life-changing event.
And maybe following up on that, Dr. Cullis, what is life like after somebody has had a stroke? And what is the treatment, the recovery period?
Important questions. Well, first of all, we have a very high-level rehabilitation unit at St. John where many of our strokes are transferred. So when we're done treating you in the medical floor, you get transferred over to the rehabilitation unit, which is run by my colleague, Dr. Raymond Bauer, where you get rehabilitation. The answer to your question depends a lot on the severity of the stroke. A lot of people have a mild stroke, they recover. For example, you might have a little weakness in your left leg. Most people can lead a normal life with that, and they're going to need some therapy, but they recover. If you wipe out the whole left side of your body, in other words, you can't move your left arm or your left leg, most people can still talk. So that's a good thing. And what usually happens in that situation, if you have a major stroke with left-sided weakness, usually you wind up being able to walk, but not perfectly, but you really can't use your left arm. If you have a stroke on the left side of your brain affecting the right side of your body, it's much more devastating, because in most people the speech area is on the left, and then you may wind up not being able to talk, having trouble walking, and not being able to use your right hand, which is a problem because most of us, our right hand is dominant. So really, if the stroke is on the left side of your brain affecting the right side of your body, it tends to be more severe. But most people get a substantial amount of recovery, especially if they're treated early. They then go into a rehabilitation program where they spend a week or two in the hospital. They then transition to an outpatient rehabilitation program with physical, occupational, and speech therapy to try to get back to as close to normal as possible. But you still have to remember that stroke is the leading cause of disability in the United States. Stroke causes more disability than any other disease in the United States.
And it might seem likely that if somebody is facing the outcome and aftermath of a stroke, depression would play a role.
Depression is very common. Whenever you develop a chronic life-altering illness, depression is an important factor. That could happen after a heart attack, it could happen after a stroke, it could happen if you develop multiple sclerosis, and that's something that we need to stay on top of. Many patients during the rehabilitation process are started on antidepressants if they're not already on antidepressants. And we have studies that show that the outcome in rehabilitation programs is better after stroke for patients who are effectively treated for their depression than those patients that aren't treated.
Interesting, interesting. And then Dr. Cullis, because of the nature of what happens to a person and the life changes that occur with that, obviously the family is an important part of treatment and recovery. And what would you have to say about that?
I think that's very true. I mean, fortunately, a lot of our patients have supportive families who can help. We find situations where people can't go home and live alone. And initially, they might need support for a few months. And so going to live with the family is important. In those people that can't be cared for by their family at home, we wind up sending them to a skilled extended care facility, a skilled nursing home, where they receive rehabilitation over a period of weeks or months with a goal to finally going home at the end of that process. But I think that the support from a family is very important. And the other issue is also stroke support groups. It's very helpful to meet with and talk to other people who have gone through the same problem that you have. And we have a support group at St. John called the Second Wind Support Group, in which patients can get together, learn about the risk factors for stroke, and speak with each other about their shared experiences. So that can be helpful for patients as well.
And are there services available to help, say, for example, a lady's mother had a stroke and she's a single parent and has a couple kids and she works, and she says, gosh, how am I going to help my mom through all this when she needs lots of care?
Right. Well, there are people in the hospital, social workers and case managers, who are very trained in terms of what community resources are available. In a lot of communities, there is adult daycare and other resources available in the community. And really the best way to find out about those is through social workers or the Department of Social Services. Because you're right, there are a lot of situations now where people are working and they can't really stay home with their mother, and they need to find an alternative situation. Mom may need to go to a skilled nursing home for a while until she gets to the point that she can be left alone, or maybe the solution would be to take her to adult daycare or some kind of adult resource in the community so that she can be watched during the day. You know, we have to do this with children, and sometimes we have to do it with grown-ups. People work and they need an alternative way of having that dependent person taken care of.
Dr. Cullis, you mentioned sort of a brain-healthy diet and the possibility of taking small dose aspirin. A lot of times people have curiosity about dietary supplements. Is there anything that you would have to say about that would help our brain in general or our neurological system?
No, there really aren't any studies that show any particular health foods are effective in preventing stroke. Really, the most effective drug is aspirin. I mean, I think what I would tell people is to eat a healthy, balanced diet. We shouldn't be eating concentrated carbohydrates. We all love cookies and candy, but they're incredibly bad for us. Carbohydrates are the enemy. I think that thinking has really shifted over the last 20 years. We used to think fats were the enemy. I think we really believe now that carbohydrates are the enemy. I don't think that we put as much emphasis on not eating fats as we did in the past. I mean, obviously you don't want to eat a lot of fat, but Within reason, it should be part of the diet. We should really try to avoid concentrated sweets. You know, bread is not a really great thing to eat.
A lot of times you go to a restaurant, you get,
Yeah.
while you're hungry and while you're waiting for things, you get a plate of bread.
Right. So the solution to that is to say no. When they say, would you like a bread basket? The answer to that question is no, because I'm as bad as everyone else. When they put that bread basket in front of me, I'm eating it. So the best thing to do is just say, no, we don't need a bread basket, thank you. And I think we should all be eating what's called a Mediterranean diet, lots of fruit, lots of vegetables, limit the amount of red meat that we're eating, try to avoid concentrated carbohydrates, olive oil as an oil as opposed to animal fats, eating fish and rice, avoiding fried food like French fries. I mean, we all know what's good for us. People don't need a lot of education on what they should and shouldn't be eating. They just need some encouragement to actually do what they know they're supposed to do.
It's harder to eat healthy.
It is very hard, but when you see people who've had strokes and heart attacks, it's a strong incentive. You know, all politics is local, all experiences are personal. For example, I quit smoking when my mother died of lung cancer.
Sure.
If your brother has a stroke who's 2 years younger than you, it's a strong stimulus, and you say to yourself, well, maybe I really should eat more healthy food because I don't want to wind up like Tom. And I think we all need to be cognizant of these risks and not wait until the horse has left the barn to close the barn door.
If somebody is listening to our program and thought that for whatever reason it might be beneficial to visit either you or the neurology department, how would they do that?
Well, there's a stroke coordinator at St. John Hospital whose name is Mackenzie Thim, Thimm, and she's actually the coordinator for the stroke program. Mm-hmm. So people could contact her for more information. We do have community outreach programs through CareLink. St. John has a program for seniors called CareLink that we put on at various places, and people could contact CareLink for that information.
Well, thank you, Dr. Cullis. Our time is up. You've been a fascinating guest, and I appreciate your time and everything you shared with us.
Thank you.
And thank you for tuning in as well. As always, we appreciate your time spent with us. Take good care of yourself and those around you, and have a great day.